So hi, I'm Dr. Joe Safdieh, the editor-in-chief of Neurology Today, and then I'm here with Dr. Michael Sperling, professor of neurology at Thomas Jefferson University. And he's going to talk to us today about a study he did regarding cenobamate presented at the FAAN annual meeting this year. So Dr. Sperling, can you tell us a little bit about your study?
Sure. This is a retrospective review of 240 patients treated with cenobamate long-term in the phase 3 trial. The phase 3 trial was conducted primarily as a safety study by SK Life Science, the manufacturer of the pharmaceutical, and we were able to obtain good quality seizure outcome data in 240 subjects from the United States to look at results. The importance of this is that the trials that are always published are the randomized placebo-controlled double-blind phase, and that gives you 3 months or so of results. But obviously, we treat people with epilepsy for years, and the question is whether the response is sustained. The result from this trial is a resounding yes to that question, that the response is sustained for an extended period of time with a median follow-up of 30 months in this trial. The drug is striking, really quite remarkable in that a significant proportion of patients who were medically refractory, had failed many other drugs prior to entering into this trial, became seizure-free on it, and the seizure freedom was sustained. So what we saw was that of the 240 subjects who entered, at about a third, 36%, had at least a 12-month period or longer with no seizures whatsoever. And at final follow-up, at final visit, when the study was terminated, a quarter had been seizure-free for 12 months or more at that time. And that's really the striking finding. So in the short-term study of a few months in the controlled trial, as I said, we saw about a quarter of patients were seizure-free. Here, during this maintenance phase, to have such a large number continue to be seizure-free for a long time really is a game changer in epilepsy.
Yeah, I agree. It does sound like it could potentially be a game changer in epilepsy. So how do you think this will impact the day-to-day practice of neurologists, and how do you think they might incorporate use of this drug in their practice?
From my personal experience at this point, it's become a drug used earlier rather than later. And I think the standard definition of intractability, a failure of 2 drugs to control seizures, might need to be changed. We'll have to see what happens, but this will be one of the things the International League Against Epilepsy needs to do, to look at our definition. When you have a drug like this, again, what will the results be after 5 or 10 years? I don't know. So we need data that way too. However, in thinking about more aggressive therapy, maybe cenobamate is a drug that will need to be used before we go into some more aggressive therapies. However, its role needs to be better defined, I think. DRESS syndrome was reported in the phase 2 trials. 3 patients out of 930 developed DRESS syndrome, or 3 subjects, I should say, out of 930, because one was a healthy volunteer. And the dosing in the phase 3 was associated with no cases of DRESS in 1,339 subjects. Once I think we have a larger number of people who've been exposed to DRESS, and my understanding at the present time in April of 2021 is that there have been over 5,000, perhaps closer to 6,000 patients who've had the drug prescribed with no cases of DRESS. Once we get a better idea of the incidence of DRESS, we'll know what the risks are and how early we can use it. And we all had the experience, those of us who are old enough, I should say, of felbamate being approved, and then once about 4,000 or 5,000 patients have been exposed, suddenly cases of aplastic anemia and liver failure occurred. It's great now that there are probably close to 7,000 people between the trial and practice exposed to the drug who have not had DRESS, using the slow titration, not the fast titration in the phase 2 trials. Once we have a much more accurate idea of the safety of the drug, then I think it may achieve much more common use. And lamotrigine is a perfect example. Stevens-Johnson was observed starting at a higher dose and titrating quickly, and now Stevens-Johnson is incredibly rare, dosing slowly. Hopefully that will prove to be the case with cenobamate, but I think we all have to be a little cautious before we know that. And that I think will discourage most of us from using it very early in the near term. Hopefully within a year or two, we'll have a good idea.
Yeah, I think that is actually very reassuring. And the lamotrigine story is also what came to mind, right? I mean, when you look at a drug when it first comes out, sometimes, lessons learned in terms of how to titrate it properly to avoid some concerns. And, I guess the real question is going to be, like you said, what the real world experience is with this drug. And, if it is sort of as safe and as effective as the phase 3 and your analysis suggests, then, perhaps we do have a game changer in epilepsy, and, we'll see where it goes. But certainly it's exciting. And, what I think, in summary, what I hear as a general neurologist from your discussion today with me is that, in the past, we learned, when I was a resident, we learned that once a patient fails two, drugs appropriately dosed for an appropriate amount of time in epilepsy, pretty much the odds of responding to a third are minimal to none. And, the fourth and the fifth and the sixth, at some point, you just have to say, maybe non-medical, non-pharmacologic approaches are the way to go. But perhaps cenobamate, is something we could add as that third, fourth, or fifth drug. And like you implied earlier, maybe even first or second in the future. So I think it's an exciting story, and it'll be interesting to see where it goes. So I want to thank you, Dr. Sperling, for giving us a few minutes of your time today. We know it's valuable, and we look forward to seeing your abstract at the meeting.
Thank you very much. It's a pleasure to see you.
Great.
Thank you.
Okay, Faye, I think